right, so why don't we get started? Welcome to our second session. My name is Mark Stenson. I'm the treasurer at the Lawrence History Center. So again, welcome to all of you, and thank you for being here. I always like to put in a plug for Lawrence History, and so we're in the historic Everett Mills. And so at lunchtime when you're walking around, even if you're leaving and you go to some of the other sessions, just imagine what this place might have looked like 100 years ago, 70 years ago when the mills were in full swing. It's an amazing space, and we're so lucky that we're able to be here today. I'm here to introduce our next session, which is on the Casey Encampment, health, social issues, and the homeless. The Casey Encampment is at Casey Bridge, which many of you probably drove over coming here today. It's the main central bridge in Lawrence. And so we're going to hear a little bit more about the tent city that's there. And this is just for me personally something I learned about probably about 5 years ago. There was a fire underneath the bridge, and many people don't realize that not only does traffic travel over it, but a lot of telecommunication wires travel underneath the bridge and connect both sides of the Merrimack River with Verizon service. So 5 years ago there was a fire, a mattress got caught on fire, and it knocked out telecommunication services through most of the Merrimack Valley, all the way up to Gloucester. And I remember reading about that in the paper and kind of realizing that there's a whole population that's living there under the bridge, and I never knew about that until that news story that I read. So anyway, today we've got two people here. Elaine Lee could not be here. She had a family emergency, so she had to leave, unfortunately. But we have Nellie DaCosta, who is the Homelessness Initiatives Coordinator for the City of Lawrence. And we have Ryan Dono, I get that right, who's the Medical Director for Homelessness Healthcare at the Greater Lawrence Family Health Center. So we'll take it away.
Thank you. So if anybody kind of sitting on this side of the room has trouble seeing the slides, I encourage you to pick up your chair and move over. Don't be shy. There are some pictures later that'll be kind of worth seeing. Elaine Lee had to cancel last night, so I apologize if part of the talk seems a little new to me as well to you, because I had to figure it out at like 5:30 this morning. So I apologize for that. And just to let you know a little bit about myself, I'm a family doctor, works at Greater Lawrence Family Health Center. I've been working in the community now for about 8 years, and recently started as the medical director of our homeless program, and do a little bit of addiction medicine. I deliver babies in the hospital and teach the residents at the health center as well. So just to kind of go over kind of our itinerary for the talk, we'll start and kind of go over some data about homelessness in the United States and in Lawrence, talk a little bit about what trauma-informed care means, and then stemming from that, talk about causes of homelessness, and then from there, talk about the Casey Encampment specifically and some of the work that Millie's been doing, and then talk about our homeless program at Greater Lawrence, and then finally kind of review some obstacles to treating the homeless, and think about some ways to kind of move forward and projects that we can work on going forward. I think we have a very diverse crowd here, so I will try not to make too much medical jargon as we go along. And if anybody has any questions or comments or thoughts, feel free to interrupt, or if something's not clear, don't be shy. Yes?
Could you stand just a little bit closer to the mic?
Oh, yeah, sure. No problem. Is that better? Thank you. So what does homelessness technically mean? The Housing and Urban Development use the definition as individuals who lack a fixed, regular, and adequate nighttime residence. It's also important to know that there is other definitions of homelessness. The McKinney-Vento Act was some legislation that was put forth in Illinois meant to protect children more so. So it includes folks that are at risk. So such as children sharing housing due to economic hardship or loss of housing, folks that are living in motels, hotels, trailer parks, campgrounds, folks that are in emergency or transitional shelters. If your primary nighttime residence is not ordinarily a regular sleeping accommodation, and folks that live in kind of public places, parks, substandard housing and bus or train stations. So depending on who you're talking to and what numbers you're looking at, sometimes people will define homelessness in different ways, and you can imagine that sometimes you will have a higher number of homeless if you look at it in different perspectives. Yeah, sure.
So to go back to those definitions of homelessness, with the Casey encampment, I don't want anybody to think there was kids down there. That wasn't the situation. But the reason that we bring up the different definitions of homelessness is because homelessness is very broad. All right, it affects different populations for different reasons and in different ways. And for those each populations, they have a different definition of homeless based on what their situation is. So we'll unpack this a little bit later, but I just want you to know that it's important to really keep an open mind as to what the definition of homeless is based on the context. We're stating, youth homelessness as well because it's part of the bigger thing, but I need people to understand that homelessness is a blanket term. It covers so much, and it's really more of a symptom of a problem than it is the problem, and we'll go into that in a bit, but I just want you to know.
So this is some data that the government put together looking at a point-in-time count. So for those of you who aren't familiar with that, on January 31st, at a set time, the country is set forth to count their homeless population. And you kind of do that organizing, depending on how you want to do it locally, with your local organizations and folks to kind of get a count of where everybody's at all at once. And so some of the benefits of that is you get a good sense of where people are. Some of the negative sides is if you think about doing it in January up in the Northeast, you're probably going to count a lot less people than you might on a summer evening. So, but at the same time, it also is counting people probably at their most vulnerable time during the winter. So you can see overall, from 2007 through 2017, that top blue line is decreasing. So overall, homeless counts have gone down. But over the past year or so, there have been increased in the amount of unsheltered people on that bottom line. And that was mostly thought to be due from some issues in major cities across the country. This slide shows what fraction of people are sheltered versus unsheltered. So you can see about a third are families that are sheltered, a third are individuals who are sheltered, and about a third are unsheltered individuals, with a very small percentage of families that are unsheltered, only about 3% nationally. And how do we rate here in Massachusetts? This slide I found encouraging and discouraging. So encouraging in the fact that Massachusetts does a pretty well job of sheltering its homeless. So you can see we rank about number 4 in the country for sheltered homeless. Only about 5.6 of our population is unsheltered, whereas in California, Nevada, and Oregon, it's kind of saddening to see how many people are actually unsheltered. And we'd like to blame that on the weather, but I don't think Oregon has typically that fantastic of weather. So, some more facts about Massachusetts here. We have about, on our point in time count, about 17,500 homeless, and about 470 or so unaccompanied homeless youth, 800 veterans, and about 1,200 of those folks were chronically homeless. And so maybe you want to talk about the Lawrence numbers here?
So the point in time count, it's an annual count that is required by HUD. And what we do with that is we have a survey that we try to have all the homeless fill out. And it really gives us an idea of, what the population is going through. What are the demographics? What are the age groups? Is there domestic violence? Is there certain diseases or mental health aspects related to it? And since last year, I also led the count before I got into this position, and it was, 101. This year we had 114, and I don't want people to think that, it's, steadily going up, because it is a possibility, but I want you to understand that we really changed the outreach methods on this, because in 2015, 15 or 16, I think we only had 45 that we counted. But really, the number was much higher. It's just that we changed the way that we did the count. So that means going to places that we know there'll be. Soup kitchens, different healthcare agencies, drop-in centers, and certain campsites. So yeah, this year it was 114 unsheltered that are outdoors, and that's only counting pregnant women once. You know, some places count pregnant women as 2 people. Total homeless population, that's very hard to, in terms of unsheltered, it's very hard to make that assessment because it's such a fluid population and they're constantly moving between Lowell, Haverhill, and Lawrence. And if I had to give you an estimate, I'd say we're probably around 140 unsheltered right now. But if we were to do this count in, say, August, we'd probably be closer to 215. Lawrence Public Schools, through them, I get a lot of communication in terms of what our youth are looking at. And, you know, a large part of this is based on the hurricane that happened in Puerto Rico and the influx of people that were getting into the city. So, you know, that's why I say that homelessness is so large and it's such a blanket kind of definition, because there's so many different reasons why it could be like that. So right now we have 144 students from the Caribbean that are enrolled in Lawrence Public Schools. 95 are considered homeless with their families, and before that we had 183 students that were technically homeless before the people from Puerto Rico came. So altogether, 278 students are homeless in Lawrence Public Schools, but we have to understand they're not unsheltered per se, but they don't have a regular housed setting. So yeah, that's a bit about that.
So now this is the part of the talk that's relatively new to me, so I apologize. So I want to talk a little bit about trauma-informed care. We'll kind of get to what that really means as we go forward. Is anyone familiar with ACEs or Adverse Childhood Experience Score? Raise your hands, just so I can get a sense of the crowd I'm talking to. Okay, all right. So this is a questionnaire that assesses kind of 10 categories, and it looks at emotional, physical, sexual abuse and neglect, domestic violence, parental separation, incarceration, mental illness, and substance abuse. And so it's I think it's on the next slide here, it's like a 10-question screen, and for every question you mark yes, you get a positive mark for your assessment. And when we initially came out with this, they looked at a cross-section of the general population, and about 67% of folks had at least one adverse childhood event when they were screened. So it's pretty common to have at least one of these. And so what does that really mean? As far as development of the brain, when we're exposed to stress, it releases kind of hormones that affect the way we develop neurocognitively, and that kind of fight or flight response can cause these hormonal changes that can cause inflammation, and it causes the way blood flows in your brain. And so if you think about when you're developing as a child, as you're exposed to this stress and hormonal changes and blood flow, your brain's going to develop in a different way than you normally would if you didn't have this amount of stress. So there's a lot of evidence that's come forward that all of this change in your development as you're a child can have some poor outcomes. So we'll go through some of those now. This kind of looks at a flow chart of how this works. So the adverse experiences kind of lead to the neurodevelopment. We're right next to a very popular street today. And as going forward, it kind of really goes into the disease and medical issues. So folks that have high amounts of adverse child events, it's been shown to increase the risk of 7 out of the 10 leading causes of death. A score of 4 and above increases your lifetime risk of heart disease and lung cancer by 3-fold, even if you don't smoke. And a score above 6 decreases your life expectancy by 20 years, which is crazy, right? So it really shows that trauma as a child really will affect your outcomes as you get older. And it even has a role in this term called epigenetics. So epigenetics is this thought that over time, when you are exposed to stress levels, it affects the way your genes are in your body. And you pass those genes on to your children, right? So there's the theory that if you're exposed to these high levels of stress, it might change your genetic makeup, and then therefore your children are more likely to have poorer health outcomes. And we've kind of thought about this, something that's very applicable to Lawrence is the Latino health paradox. And we find that a lot of Hispanic immigrants, when they first come to this country, are actually in quite excellent health. And it makes sense because to get here, you have to probably have the means and be a healthy person to get yourself here. Over time, though, our society takes a toll on folks, and when you have to work however many hours you have to work to be successful, and you have to overcome all these societal barriers, you're constantly exposed to stress. And so some of it, we know that over time, immigrants, like in their second and third generations, have much worse health outcomes. And so some of the thought is that maybe this epigenetics is playing a role, and if you're altering DNA and passing it on to your children, maybe that's why people are having poor health outcomes. So the same kind of thing applies here, and perhaps is affecting the children of folks who are kind of constantly exposed to stress. And so the behavioral risk factor surveillance study is a national kind of study that looks at risk behaviors. They found that the relationship between these ACEs and homelessness is directly proportional. So if you kind of look down below, for an ACE score of greater than 6, about 27% of those folks have homelessness at some point in their life, whereas only 2% of folks who have a score of 0 to 1 end up being homeless. And then kind of further kind of moving with this is domestic violence. So 69% of women who are homeless have been raped or had trauma in their background, and 69% of domestic violence victims report childhood sexual abuse, while 73% of male batterers were abused as children. So you can kind of see how domestic violence definitely plays a role in trauma and definitely plays a role in kind of your health outcomes going forward. And just some more stats here, but 80% of childhood abuse cases are connected to drug and alcohol. There's 3 million children witness violent acts against their mother annually. 4 to 10 of those kids will have violent adult relationships in their futures, and 30 to 40% of abused kids will abuse family members later in life. So how does this relate to the homeless? We know that ACEs and stress negatively affect health outcomes, and the vast majority of homeless have experienced significant trauma, especially in their development. And if we want to affect their health outcomes, we need to really be addressing trauma going forward. And so the basis of trauma-informed care kind of comes into play, and we need to acknowledge that both our patients and potentially the providers, since we know that a large portion of folks have at least one of those events during their life, we need to acknowledge that both our patients and the providers can be re-traumatized in entering healthcare, and it's very important to kind of keep that in mind as we provide care to folks. And while trauma is not necessarily the sole cause of homelessness, it definitely plays an underlying theme in caring for this population. And so now, I think, Mary, I'll hand it over to you. Does that all make sense to everybody? Yeah?
Okay, well, there's a point. That's cool. All right, so let me reintroduce myself. My name is Louis DeCosta. I'm the Homelessness Initiatives Coordinator for the City of Lawrence under the Mayor's Health Task Force. I've been in this position for a little over a year, and the way this came about was, various coalitions and people in the Mayor's Health Task Force noticing that there is a trend that always comes back to homelessness. We look at a lot of health disparities, and they're very entwined in there. So part of what I do is, my main responsibilities, cross-coordinate efforts between nonprofits, the municipality, and the state agencies. So it sounds basic, but before I was here, we didn't have that kind of communication where Department of Public Works, DMH, and a religious group were all in the same room trying to brain solve a problem that is quite systemic and quite large. I work with various agencies, officials, coalitions to find overlaps and gaps in services. And that's why I work so closely with the health center. When we look at those services, those gaps, they are directly tied to healthcare. And it's not that it's strictly only healthcare, but it's always an essential part of it. So that's the kind of lens that we try to look through when we try to examine these problems. That's how you get to systemic root causes. In addition to that, one of the big things was, how do we approach encampments to protect the well-being of those in the encampments who are very high risk, very vulnerable, as well as those in the community that are, whether they realize it or not, directly impacted by the homeless population and the trials and tribulations that they face, because we're all in a shared space. This city is only 7 miles, and we are very populated out here. And we're under census reported as well. So you have to keep in mind that it's a large population, and it's easy to fall into homelessness, but we have to understand that, once again, homelessness is a very broad thing. So approaching encampments, not easy. It's a very complex situation, and I'll get into that. But in addition, I act as a consultant and liaison to the mayor's office, and how do we, not just think about the community and our constituents, but what about these people that are, at risk for disease, violence, so forth. And then examine health disparities within this population and various other populations, because at the end of the day, a lot of us, we're just one paycheck away from being homeless. It's a circumstance, and it's easy to fall into, but there's many reasons why you get to that point. So, under the Mayor's Health Task Force, I have a working group. We have the Homelessness Initiatives Working Group, and with the help of the Institute of Community Health, we did a root cause analysis, and a lot of this data was drawn out by my open hours at the library on Fridays, where anybody that's homeless or feels that they're at risk of being homeless can come in, consult with me, and I'll give them referrals to whatever they need. But these are the things that pop up most frequently. And I want you to really keep an open mind to this and see how trauma is intertwined with a lot of these. So mental illness, disability, domestic violence, post-traumatic stress and trauma, rising rent prices and evictions, medical ailments, physical disability, addiction, fire and natural devastation, gender identity and sexual orientation, pregnancy, larger numbers in teens and young adults, unemployment, family or spouse death, and a history of incarceration. So when you look at that, those are the things that, were there before the homelessness came. The thing is, when they're homeless, that's when we really see how far it's permeated and how far it's come along. So this is why trauma-informed care is so important. We want to try to be proactive rather than reactive. How do we reach these populations before it gets so severe? So before I go into the systems and the populations affected, is everybody here familiar with the Casey Encampment? Or show of hands, who here has heard of the Casey Encampment or Tent City? All right, cool. I should say, who hasn't heard of it? Clemens, I know you've heard of it. Put your hand up. Okay. Okay. So the Casey Encampment it was located under the Casey Bridge, right here in Pemberton Park. So we were to drive down Essex Street and make a left right when you're on, Amesbury Street? And then keep driving. You make that first right after Canal Street. You're in Pemberton Park, and it's a really nice park. It's right on the water. It's beautiful. But under this bridge provided a lot of shelter for a lot of homeless individuals. A lot of those with dual diagnosis, meaning they have a substance use disorder, as well as another mental illness, and various other problems. So we had a lot of people leaving domestic violence situations. We had a lot of mental illness. We had a lot of people that just had a rough go at it and made some decisions that escalated. So under there were 4 different bays under this bridge. Altogether, I had about 60 people living in this encampment. This was one of the largest encampments in New England. And by the time it closed down, it was probably one of the largest drug hubs in New England as well. So that's where you really have to take a step back and look at it as more than just an encampment and what it really was. So it's a very complex situation, and I'll get into it right now. So with the Casey encampment, here, let me do this. Can anybody see that? I know it's kind of tiny. This is why I told everybody to come up, but if you don't, well, it's whatever. Yeah. Okay. So, yeah.
Here's the park.
How do I do this thing?
Under the bridge here.
All right. So, this doesn't do anything. Okay. Okay, you can see it? All right. So right here is under the bridge. This is the Casey Bridge going this way. That's 114. Underneath there were the 4 bays. And, you think it's just a homeless encampment, it's just a homeless encampment, but this is a very busy area right here. You need to understand that right here we have Kid Start, which is a preschool. So next to all this prostitution, drug dealing, all that, we had children right here playing back here, so it wasn't uncommon for these kids to have to go indoors because somebody's overdosing right by the playground. In addition to that, you'll see that this really took a toll on the river as well. It's right by the river. So just imagine the amount of things that were coming out of the encampment and slipping into the river. And, we're talking syringes, human fecal matter, litter, everything. Even dead animals that would die from being in the presence of all of this. So in addition to that, we're in a housing shortage as well right now. So another thing is, right there, that's really solving properties. We were trying to turn those into housing units, something we desperately need. But this encampment sat in the way of it. And we found that a lot of the trash and the litter and the vermin that were attracted to the encampment would go into really solving properties which were being reconstructed, and suddenly we had vermin in the middle eating the insulation. So you see how the population here, which has been brought here because of various situations, various traumas, it doesn't just affect that population, it affects those around it. And this is one of our nicest parks. It has a water view picture. The family resource center is right there. Well, children, friends, and family right there. And it's a very complex thing. So trying to shut down this encampment for the betterment of the community was no easy task. There was many populations involved. So environmental, we have to keep in mind, all right, we have one of the biggest encampments with thousands of syringes right next to a river. And we were seeing these syringes slowly slide in the garbage into the river. And I'll show you pictures later. Wildlife, we started noticing a lot of dead birds, squirrels, rodents, vermin. It was pretty bad. And another thing is when the animals died within the encampment, they'd be thrown into the river too. Many reasons for that. There's a lot of debris, garbage under there, but also we got to understand fentanyl as well. Fentanyl residue all over this place. And I'll get into that in a little bit to give you more insight. Housing, we talked about very solving properties in the Pacific Mills. So it affected environment, wildlife, housing, youth from Kid Start, and I'll explain more about a lot of people that don't understand the situation will say, who would send their kid to Kid Start? Well, they take vouchers. That's a lot of hardworking families that can't make it without, those vouchers from our, community organizations to help them pay for their child's education. So just because a person's economic status doesn't mean they don't deserve a quality education environment. And then lastly, we're talking open spaces and active living. Mary's Health Task Force, we're always pushing activity outdoors. We're constantly trying to activate our spaces. But it's kind of hard to do that when we have syringes all over this park. We had syringes getting into the waterways, and it was also near a school ground. We've since put a fence around the school ground, so nobody can get in there. But it was a very convoluted process, trying to think of all these different systems at play and what is best for the high-risk individuals that are in this encampment, but what is also best for the community at large and different systems at play. So, I showed you the picture of this, and here we go. So this is a picture from the last bay of the encampment. And what it is you're looking at a lot of debris and stuff that was just getting into the river. So right here, you'll see that was a slope, and we would see the syringes just sliding into the river. And I mean a lot of syringes, okay? So, you have to understand it's really affecting wildlife, it's really affecting the environment, because there were a lot of syringes just slipping into the water. This is all that we got just off that ledge, all right? So that's a lot of syringes. We put it in a sharps container. And the thing is, people are always like, why are there so many syringes out there right now? And I'll explain that. So we have our syringe exchange program in the city, where people are like, why are there still so many syringes? The thing is, this isn't heroin that we're dealing with anymore. This is fentanyl. I can't recall the last time I even saw heroin. It's all fentanyl right now. And the thing about that is, fentanyl provides a much larger high, but it's much shorter. So before, I had my guys would probably shoot up heroin 4 to 6 times a day. Well, these highs only last about 15 minutes. So on average, I'd say most of my guys are shooting up about 20 times a day. We had on record the person that shot up the most was a young girl that was shooting up about 40 times a day. So that's why you need the syringes, because one, it prevents the transfer of diseases. It prevents abscesses, endocarditis, various infections throughout the body. And so there was the need for that, and this has prevented things to some extent, but it still doesn't just affect the population that's using the syringes, but those around them. So that's just where we stop from getting into the river. It's not even the whole encampment. So, for this encampment, there would be tons and tons of garbage, and I mean literal tons, and it was no easy process trying to clean this up because of how dangerous it was. So, this is what the animals were getting into. Found a lot of dead squirrels, a lot of dead birds amongst the trash and debris. So we knew there was a definite problem, and it's no easy task cleaning this up because we can't just go in there and pick up the garbage like we usually would. We needed a bobcat to put it in a pickup truck first, because as we pick up the garbage and shake it, you'd see syringes just trickle down. So, it wasn't easy, but it was also costing the city a lot. We were spending thousands and thousands and thousands of dollars to try to remove that garbage on a monthly by monthly basis. So a lot of that, we could have used in other ways, but it was patchwork, and that's the thing. When we talk about trauma, you need to be proactive and preventative. You don't want to let things escalate, because then you just start doing the patchwork. You're not actually solving the problem. You're just trying to put a Band-Aid on the problem. And it affects wildlife. So I don't know if you can see this picture, but that is I don't really know animals. It's not a dog. What is that?
It looks like an otter or a beaver or something.
So an otter or a beaver or something, but you'll see that it has a jar stuck on top of its head. This wasn't uncommon, animals would get into the debris, and then it's not uncommon for you to see a squirrel with a syringe in it or garbage on top of the head, So this was affecting more populations than we give it credit for. This is under one of the bays of the bridge, so you see just amongst the garbage how much we have going on here. We got tons of syringes, all right? And we have condoms, all sorts of stuff. And the thing about the bridge is a lot of people remember bringing food and stuff down there, and, they're quote-unquote helping, but really, we were actually putting people in more harm's way. Because one, you were setting things up on top of fecal matter. I'd see church groups come set up on tables that were covered in feces. And then now we have homeless people eating that. In addition, we'd have people bringing them goods, which weren't really necessary at the time. So, There was a flea market across the parking lot, so it's a one-stop shop. Here, you drop off donations, they take the donations, they sell them at the flea market, you get drugs. It's a one-stop shop. So you gotta understand the systems at play, the things that are in the area. And yeah, that's one of our larger shutters containers. So that's just out of one of the bays under the bridge. That's probably around 2,000 syringes. But yeah, so we're talking, you know, a lot of biohazard material. So not only was this in our community, but we had a population that was living amongst this. And we were allowing them to live like this, you know. There was a lot of prostitution under there. So when we talk about diseases, we don't know what was spread through prostitution. We're mostly looking at what was spread through intravenous use. And also, it was just such a cover-up for so many things as well. You didn't realize that people would come down saying, hey, I'm taking so-and-so to detox, when you're really just taking them behind the school bus, and it's, you know what it is. So taking the bird's eye view of it, what is best for the population, what is best for the surrounding area, so we realized there was no way around it. We really did have to close it down. And yeah, I know, not positive, happy talk right now, but this is the reality of the situation. So yeah, they're living amongst filth, disease, so forth, but you know, when you go down there, you just see people after the initial problems have really progressed. You know, what started off as just a domestic violence situation at home, or you know, somebody just drinking a little bit too much. These things escalate when there isn't the proper mental health and physical health supports that are necessary. So, you know, we realize that you can't go that far. Here we have, you know, just filth and debris of what was in the encampment, seen Narcan on the floor, and, you know, boxes of syringes. But, you know, we have to understand this was happening in our community, and this was not just our community as well. These were people from all over the place. A lot of people from New Hampshire. So yeah. So how are we going to be proactive in that? How did we shut it down? So I worked with a lot of various agencies, one of them being Greater Lawrence Family Health Center. But we really tried to identify who was down here, what were their ailments, what did they need? Did anybody need to be signed up for mass health? Who needed prenatal care? Who needed to be sectioned? Who needed whatever it may be? There's a variety of illnesses down there, and you know, trying to cross-coordinate efforts with agencies, the police department, the fire department, DPW, DPH, DMH, that was no easy task, but we did it. So I'll be handing it over to Ryan to explain how we were a little bit more proactive.
So I hate to carry on that conversation. So you describe a very bleak situation under the bridge, right?
Yeah.
Hopefully I will bring some more light to the picture now. But I think one of the great things of having an encampment like that was it gave us great access to treat patients. We were able to bring our mobile unit there, and then since then, after the encampment has broken up, it's really hard to track people and really hard to find people. So we found that we really have to rely on working together as a team amongst the health center in Lilly and the health center and the police department, and we'll kind of talk about things that we're doing to kind of go forward with that. So just to give you a taste of what we do at the health center, so our homeless program is, the goal is to provide accessible care to marginalized population, lower barriers to care, meet clients where they are, offer trauma-informed care, and domestic violence outreach. So we currently operate at 13 shelters, food pantries, churches, with clinics inside of those buildings, and then we also have a mobile health unit. We have about 7 doctors, 1 nurse, a medical assistant, and 1 community health worker. And then we have 1 outreach worker / driver who does the exchange. He drives the mobile unit. And we coordinate care with our HIV team, street outreach workers,
We have pharmacy coverage for medication, so if folks can't afford their copays or just in general they don't have insurance, we can cover their medications for a short period of time. And we get folks access to Narcan, which is the medication that cures an overdose. And we also have some money reserved to help folks get IDs and the like. So this is kind of a list of some of our major sites that we're working at. I'll go through them relatively quickly. So we go to YWCA. The YWCA has an Oasis program, an SRO program, and an emergency shelter for victims of domestic violence. We're able to go to most of their sites. Daybreak Shelter is the major emergency shelter here in Lawrence. They house, I believe, up to 45 people. 40? Okay. And it's first come, first served. You can be under the influence of alcohol, drugs when you're there. Everybody gets access to a shower and a meal. And here's kind of where they're set up on Winter Street. Not the most ideal living situation, but it's a shelter over your head when it's cold and wet. Bread and Roses is a food pantry. Soup kitchen, sorry, my mistake. We kind of operate a clinic out of that window there, I think. And they serve over 200 meals a day. And also have emergency food supplies for 2 to 3 days on a case-by-case basis. I believe they're also doing outreach and delivering those to folks these days too. Rich's Place is a homeless shelter in Haverhill. And they can cover up, that's what I was giving you, 45, they cover up to 45 people during the winter and 30 kind of year round. Emmaus Family House serves up to 54 homeless families, 28 of which are in a congregate setting, and then 26 are kind of scattered in apartments throughout Haverhill. We go to the drop-in center, which is in the basement of the Universalist Unitarian Church in Haverhill. And see folks there. It's a day program for homeless folks. We go out to Lowell in the Transitional Living Center, which is their major homeless shelter that serves up to 135 people in the winter and 90 during the summer. They also have some single apartments. And we also go down to Tewksbury and serve folks in a transitional center that is mostly meant for folks kind of between detox and halfway housing. And while they're there waiting for their halfway house, which is usually a long wait list, we'll see them for the 1 to 3 months that they're kind of hanging out waiting for that. And then with the mobile unit, so the mobile unit it's actually a beautiful thing. I'll show you some pictures in a second. But it's really remarkable in that it gives us an ability to kind of go where anybody is. When you set up a clinic in one of the shelters, you have to get HRSA approval, and it's a process, and you need to apply, and somebody needs to investigate it and make sure it's all up to code, and yada, yada, yada. Whereas when you have a mobile unit, all you have to do is get permission from the city to park it somewhere, and you can see people because the site itself is in the unit, so you can take it wherever you want. So it's really allowed us to kind of move around and try and track people where they are. This is outside of the House of Mercy, which is a day program for homeless folks. We have a generator, so it can stay cool in the summer and warm in the winter. It also has an awning that kind of goes out and protects people from the rain if they want to hang out outside the mobile unit. We were able to get this through fundraising. And we have 2 exam rooms, all with the necessities in a normal exam room. You can check eyes and ears and do a pelvic exam if you need to do one. We have a little waiting room here with a bench for people to sit. There's a sink to wash your hands, a bathroom. We have a defibrillator machine that we can use to do EKGs and if somebody were to, heaven forbid, have a heart attack. We're able to draw labs here. Collect blood samples and send them off to the lab, and there's a refrigerator to store vaccines. And so with the mobile unit, we've been able to go initially under the bridge before that encampment was broken up. And then since then, we've kind of gone to a whole host of different places.
These days we're set up outside of the YMCA men's shelter. We're about to start going to Casa Maria, and then we're also going outside of the House of Mercy these days. So why is it, how are we doing with time? We need to finish by 12:30? Okay. So actually Dr. Coe had done this study that I'm quoting in here. I don't think he's here. Hopefully I don't misquote your information from the study. But the Boston Healthcare for the Homeless had looked at street deaths in the late 1990s through 2003. And they were trying to figure out how to solve, how to prevent people from dying on the streets. And they started to track folks. And the folks that they tracked were high-risk individuals. And those that they identified as high risk were folks with substance abuse, persistent mental illness, and chronic medical diseases, people that had been admitted to the hospital, folks that are over 60, have HIV, liver disease, kidney disease, and or have had issues with frostbite, hypothermia, or something called immersion foot, which is kind of a similar thing to frostbite. And so once they assessed who was high risk, they started tracking them and then worked as a community, coordinating care amongst hospitals, healthcare workers, the emergency ambulance companies, substance abuse providers, shelter providers, police, and various city organizations. And so they would have a meeting where they would discuss these high-risk folks. And were able to reduce their annual street deaths from around 24 to 30 annually down to 16, which I think is a pretty remarkable thing. And it kind of really shows kind of the theme for today in public health and the need that we need to collaborate across different organizations. I wanted to go through briefly these following things and some of the things that we encounter as far as obstacles in caring for the homeless. First off, it's really important to deliver care to the homeless because 73% of them have at least one unmet health need, which is significant. And this directly will affect their ability to have preventative care, to have prenatal care for their pregnancies, and affect health outcomes. So mental health disease is an issue. We know that folks that have significant mental health burden are much more likely to be chronically homeless. And accessing mental health services is very, very difficult here in Lawrence. There's often 1 to 3 month waiting lists to get therapy, and we do have some therapists and psychiatrists that work in our health center these days, so that's been helpful. So we're able to kind of collaborate with them. But oftentimes, as a primary care doc, I'm left managing their 7 psychiatric meds sometimes, and it can be a challenge because I didn't get training as a psychiatrist. I'm just a family doctor. So that's definitely an obstacle that we face. And disability, to kind of go along with that, is also a major issue. It's really hard to afford housing if you're disabled, and if you are unable to apply for disability effectively because you're homeless, then it's often something that will lead to you kind of being in the cycle of chronically homeless. So I kind of talked about this already, but there's a significant transient population at this point. Before they were stabilized under in the Casey encampment, but now we're having to track folks. They've kind of dispersed into the community, and it's been really hard to kind of locate them. So working with Millie in the city has been essential. Sometimes we're only able to access folks when they're getting services. So when they're getting their monthly payment, or if they're going to access like the House of Mercy and things like that. It really relies on us to have an active outreach program. And so our health center has outreach workers that are going out into the community all the time and doing needle exchange and testing for HIV and other sexually transmitted diseases. And so I don't know if a lot of you were at the last talk with Dr. Basitis and company talking about the HIV outbreak. Yes, no? Half? Not a ton. So HIV is a problem. There was a recent article in the Boston Globe a couple of days ago, and the article made it sound like it's a mystery as far as why people are getting HIV, but it's not so much of a mystery. IV drug use is a major contributor to this. And so typically at the health center, we get about 10 to 15 new diagnoses a year. We have well over 30 in this past year. So there's definitely an epidemic, and the CDC is interested in helping us figure that out and how to maintain, and how to, not maintain, but to how to stop it from worsening. Typically, about 10 to 20% of those folks are IV drug users. This past year, it was 61%. And a large portion of these folks, 58%, are homeless. Almost 100% of them are also co-infected with hepatitis C, which does not help your likelihood of having significant medical issues with HIV. And about 61% of these folks are hard to engage, so they've been hard to track. All but one of them are homeless. And so, assuming that our homeless population is around 100 to 150, that puts our HIV prevalence at 15%, whereas the country as a whole in Massachusetts is about 0.3%. So if you were to look at that kind of like internationally and were to compare our homeless population, this is not apples to apples, but if you were to compare our homeless population to the rest of the world, we'd rank number 5 as far as HIV prevalence in the world, which is kind of crazy. Substance abuse, kind of understandably so, is an obstacle to providing folks with adequate care. Addiction often leads to folks to isolate, have no support, it stigmatizes them, leads to financial instability, and as a result kind of subsequently has folks difficulty getting into appointments. Another major thing that's an issue is documentation. So when people are homeless, they often use the right methods of identification. And so if you don't have an ID, it's hard to apply for disability, it's hard to apply for insurance. So our outreach workers do a daily job of trying to get folks their identification. Something that kind of goes along with that is folks that are incarcerated. So after incarceration, once you go into the jails, you often lose your insurance, you lose your benefits, you no longer have employment, you lose your connection to society, and then you get released back into society and are expected to kind of all of a sudden figure everything back out again. And often a significant risk factor for overdoses in the community is when you get released from prison because you've been forced to be sober for the past however many months or years, and then all of a sudden you go back and have a relapse. The likelihood that you overdose is significantly higher. Managing a budget for such a program is a challenge. We work in a federally qualified health center, which is not exactly loaded with money. And caring for these folks is not exactly a financial bonus. They take longer to take care of. And especially in primary care these days, we're driven on visit numbers and seeing people as fast as possible, but it's not exactly the ideal situation you want when caring for homeless folks. So we kind of supplement that through grant funding and drawing in from the health center's other kind of profits to help support us. We talked a little bit about this, but stable housing is absolutely essential for caring for homeless. If you can't get stable housing, the likelihood that you're going to be gainfully employed and able to take care of yourself is significant. And so this is from the U.S. Census, and if you look, this pointer does not work so well. If you look in the first red box there, about 76% of housing in Lawrence for rent is between $500 and $1,500 a month. And the other red box down below shows that about 50% of rent as a percentage of your income is more than 35% of your income. So that's a large burden on folks to afford housing. And then just to note, the GLBTQ, which is for, I'm assuming most people probably know what that means, but for gay, lesbian, bisexual, transsexual, and queer folk, it's a significant burden amongst homeless. About 20% of homeless youth are in this community. And we know that GLBTQ youth have higher rates of victimization, mental health issues. They're 7.4 times more likely to experience acts of sexual violence over heterosexual homeless youth. And also really important to know that these folks have significant higher rates of suicide, 62% versus 29% of heterosexual homeless youth. And another thing to think about, kind of going along with the lines of having an encampment, is when you want to set up a mobile unit, you have to think about visibility and stigma in the community. So approaching the mayor's office to set up a clinic right in the middle of the Central Park in Lawrence may or may not be received so positively because it kind of is an advertisement that, hey, we're treating homeless folks. So we always have to think about balancing where to find people and how visible you are, but you don't want to be so invisible that you're off in the corners and further contributing to the stigma of homelessness that these people need to be off in the corners. And so it's kind of a tricky balance that we play in trying to set up locations. And then I just wanted to touch base a few slides on women's health and homelessness. And it's really important, kind of going back to the history of trauma, to realize that the major cause for homelessness in women is domestic violence. So 20 to 50% of all homeless women and children are homeless as a direct result of fleeing domestic violence. And then if you think about it, once you are now homeless, the lack of security and unsafe living conditions puts you at a significantly higher risk for having assault. This results in higher rates of depression and mental health problems. And thinking about pregnancies, homeless women have higher rates of unintended pregnancies. They're more likely to have preterm deliveries, and they're more likely to have smaller babies at delivery. So kind of thinking about hope and the way forward, and I hope that we can kind of talk a little bit about this as a group now. So how do we go forward? How do we work as a community to better treat our homeless with dignity and respect, and making sure that we're meeting all of their unmet needs? So some of the stuff that we've been doing, I've kind of listed here, and we've talked a little bit about some of them. But we're going to start doing some addiction management on our mobile unit. We're working on increasing our collaborative work with our HIV teams at the health center. There's a hub meeting that I believe the police have been the leaders in that.
LMCC and the police department.
So the Lawrence Methuen Community Coalition and the Lawrence Police Department have created these hub meetings that invite local organizations, kind of like the theme of the Boston Healthcare for the Homeless and how they reduced street deaths, and reviewing high-risk cases.
I could talk a little bit more about that.
Yeah, you want to talk now?
Sure.
So, I mean, I work closely in all of these areas, so I can tell you a bit about what we have been doing in the city. So, for one, I do have my working group, and that is composed of state agencies, city departments, various nonprofits throughout the city. And what we do is we try to meet monthly so that we're not operating in silos. We know the population, but we need to know each other as well, so we can approach this from a unified front. And what that does is we're able to get more localized data. We're able to figure out what's happening more in real time. We're able to establish partnerships that we've never even thought of before. And then also we're just able to bring, different resources to the table that we haven't used before and use them in a different way. And with the hub meetings, that was started by Lieutenant Dan Fleming of the Lawrence Police. And he brought me on immediately once he started that. And I brought a lot of people from my coalition to those meetings. And what it is when somebody's deemed very high risk, we try to prioritize that person. So if the police report that somebody has overdosed and they do Narcan on, we will the next day go out, try to find that person. We will try to make sure that they are, one, medically cleared. We offer them services. If you would like to go into a detox or form some sort of treatment plan, if they have outstanding warrants, we'll go before the courts to try to clear those warrants so long as they agree to go into a program and do whatever it may be for them to stabilize themselves. So having that kind of wraparound approach has really changed things a lot because, overdoses happen on a regular basis now. And, what do you do with that person when, you Narcan them and then they get up just to go out and do what they did before? So trying to be proactive in that way. In other ways forward, we really do try to change the way we do outreach. And I meet with Water Street at least twice a week to figure out what are we seeing out in the streets, where's the population moving, how do we reach that population, who are the most high-risk individuals in that population, and how do we help them? I'll hand it back over to Ryan right now.
Yeah, and just a few other thoughts is we do train residents, so incorporating these doctors in training in kind of directly accessing homeless healthcare hopefully will lead to them being more likely to do that when they leave. And that's pretty much the majority of everything that I wanted to say. Does anybody have any questions, comments, thoughts? So the question was, can I assess cost of an overdose kind of societally and using that as a way to fund our efforts? I can't quote you any numbers. Yeah. Okay.
All right. Yeah, I got the answer. All right. So Narcan is not cheap. All right. And through our SSP program on Water Street, we are able to distribute Narcan. But, luckily we upped the dosage of Narcan. Before it was only 2 milligrams. Last time I had Narcan somebody, it took me 16 milligrams. So, we upped it to 4. So that's still a lot that we have to do. But, 1 pack of Narcan for the rate at which we get it, roughly about $60. And then, there's also the cost of if they do accept treatment and go to a hospital. The way HUD outlined it, we spend at least $30,000 in emergency room visits per homeless individual. And that's an older statistic, so it's only gone up more because we're seeing people entering the emergency room more and more frequently. And that's why we really did push for the mobile health unit because, this is a way to be preventative. They don't have to seek out the emergency room for everything. This is where the preventative care comes in, and that's how you really cut the costs. And in addition to that, that's also why we have safe syringe programs because it does save a lot in the long run. And it not only cuts down on the transfer of diseases, but, it prevents those trips to the emergency room because of the abscess, because of the endocarditis, because of the cellulitis. It's a couple $1,000, away from all that. And that's not even including detox. Every time we send somebody to detox, that's about $30,000. And on average, we're sending each addict to detox about 5 times a year. I have about, right now I know for a fact I have at least 110 active users in the city, so you multiply that by 5 and then multiply that by 30,000. It's quite expensive. That's why, there is the housing first model, because you find that housing people first is always the cheaper way to go. Because between shelter stays, hospital stays, and so forth, it really adds up a lot more in the long run. So the way that we did that was, we tried to form relationships with various shelters throughout the state, and we offered people chances. Like, we didn't just go down there and move them all out in one sweep. We put the mobile police unit down there, one to monitor the area, and then have different social service agencies checking with the police before approaching the population. So that way we can figure out what exactly we need for them. So we did get some people in the treatment, we did get some people in the housing, but a lot of them, the thing about addiction is you can only really confront that when you're ready to confront that. So a lot of them weren't ready. And then also, another thing we found about that population was, especially from people from New Hampshire, they weren't actually homeless. They were kind of just, they treated this as Vegas. Like, what happens here stays here, but that's not how diseases work. They did, some moved to other cities, some moved to other part of this city, others went back to their families, but the way that we try to look at it is we were going to make it as hard as possible for you to actively use drugs and as easy as possible for you to get help.
Just to go back to the money question from before, so if you were to think about saving money on overdoses from a primary care clinic standpoint, it doesn't save us any money because they go to the emergency room, and at the end of the day, who's going to give us more money for preventing someone going to the emergency room? But now that we have an ACO in the community, so I'm not sure if everybody's familiar, but the Massachusetts has established a bunch of accountable care organizations throughout the state, and I think there's hope with that going forward, because once you pool the hospitals and the primary care clinics and the specialists and the emergency rooms all into the same financial pool, then there's maybe more of an incentive to kind of support preventative measures for people overdosing rather than kind of us trying to do it on our own as a health center. So.
Yeah, fantastic presentation, by the way, very comprehensive, very informative for me. You guys alluded to it earlier in terms of the root causes. I know there's like a heavy immediate need, right, where we're going to have to be providing these direct services for a very long time, right? But is there any collaboration or kind of influencing or providing research to policymakers, or like, because like this is a national, not issue, right? It's a global issue. Is there any way that this research and this work is influencing or like assisting like the labor movement to like help provide more jobs and collective bargaining in some way to like provide social supports so that homelessness never occurs in the first place?
I don't know if you have an easy response to that.
Okay, yeah, that's always that loaded question of like, all right, how do we end homelessness? Well, homelessness is part of the human condition, so I'm always going to give you that, you asked that question, I'm going to give you this answer. How do you end homelessness? With homes. But that's not really, what it comes down to, because even if we did put these people in homes, there's still these underlying issues that they're facing. They still have these health issues, these mental health issues, and in some cases we're finding that if we can't get them into supportive housing, then it's not good for them to be put into just independent housing, because if you put somebody with an addiction in a rooming house, they're not going to thrive, All that happens is you just have an overdosed person behind closed doors in a decaying body. You know what I mean? We have to think about this. What is the real problem beneath all of this? That drug addiction came before the homelessness. You got to confront that drug addiction. In terms of how are we influencing each other and with our data, yeah, we're constantly talking to DPH, DMH. They know what's going on. Working with the Institute of Community Health, different policymakers. It's up to them to use the information, but we make it available for them. Even some of the things that we're doing now, like the hub meetings, that started in Europe. We're taking a model from a different country. Cambridge did it, it worked out well for them. We're taking it from Cambridge and trying to figure out how they do it. It's all about doing it locally and putting your own spin on it. What are your strengths, what are your weaknesses, and how do we work together to bridge those gaps?
I would just add, I think it's really important to vote as a community, because we really need to put people in power that are going to empower these things to move forward. I won't get into too much of a political response, but I think we need to vote and encourage our fellow Americans to vote. So.
Good. Any other questions before we wrap the session up? No? So just thank you, Ryan, and Mary, for being here. That was a great presentation. I think we all enjoyed hearing the collaboration that's happening here in Lawrence and some of these issues that maybe all of us didn't really know about, how the depths of some of these problems and how they're being addressed. So thank you once again for coming and sharing with us.